Well, thank you, Tom. I would like to thank the organizing committee for the opportunity to be here. I think given its history and its membership, in my mind at least, the British Hypertension Society is certainly one of the most prestigious in the world. So it's a great honor to have this opportunity to present. By way of conflicts, I think the only thing that might be relevant is I am serving as a consultant for a very small startup company in California who are developing a very novel device for treating resistant hypertension. I will not speak to it at all, as nothing has been published. What I'd like to do in this talk is propose yet another category of hypertension, if you will, that we are referring to as refractory hypertension. And the distinction in our mind is difficult to treat hypertension versus impossible to treat hypertension, if you will. So that is hypertension that's resistant to pharmacologic intervention versus patients who are really failing a maximum antihypertensive therapy. So I'd like to discuss how we are proposing, so it's a very extreme phenotype, obviously. So I'd like to discuss how we are proposing that it be defined and show you some early data that we've published so far on this phenotype. By way of background, I would like to discuss some points relevant or relating to resistant hypertension that are going to be relevant in terms of now this refractory phenotype, how some of the distinctions, both in terms of mechanism, or mostly in terms of mechanism, and then where we hope to be going from here. Just very quickly, I'm sure well known to this group, resistant hypertension has been defined for many decades now, largely attempting to identify patients with difficult to treat hypertension. That is difficult meaning largely resistant to pharmacologic intervention. It historically has been defined as needing 3 or more medications, including a diuretic. I had the privilege of chairing this AHA scientific statement on resistant hypertension published now 7 years ago. And I think in that statement, the definition was consistent with what had been published, again, for many years, except as a committee, we did create a new category of resistant hypertension that we referred to as controlled resistant hypertension. In the earlier statements, it was interesting that the definition was seemingly based only on uncontrolled hypertension. So you had resistant hypertension if you were uncontrolled on 3 medications, but if you were subsequently controlled on 4 or 5 or 6, you no longer had resistant hypertension. Just from a clinical standpoint, I always had difficulty with that. If a patient is needing 5, 6, or 7 medications, even though eventually controlled, in my mind, that's still difficult to treat. And so as a committee, we felt that to be the case, and so we felt like we should still consider those patients difficult to treat, and so should still be referred to as controlled resistant. I emphasize that now because I really did not anticipate it being very controversial. To me, it seemed intuitive almost, but it was, and I still, to this day, get harassed a little bit about including that category of patients. Again, in a lot of people's mind, if I can control it, then certainly it's not resistant anymore, hypertension. But I mention it now because we have settled in on this group of patients as our control patients for the patients that we are then going to are labeling as having refractory hypertension. So this concept of controlled resistant hypertension, so patients needing more than 3 medications, but in whom we can control their blood pressure. Just in terms of some background information, prevalence, I think resistant hypertension, at least in terms of based solely on the number of medications prescribed, is a very common disorder, unfortunately, and likely, and no doubt is becoming even more so. This is data that Bill Elliott did while he was at Rush. He's now in Yakima, Washington. But this is using NHANES data set, looking at estimated prevalence of resistant hypertension. You can see from the late 1980s to 2008. And you can see the prevalence has progressively increased. And most recently, this is, of course, U.S. data, but most recently as high as 21% of patients were needing 3 or more medications, at least prescribed 3 or more medications. And you can see how the prevalence seemingly has increased progressively over that time period. That increase to me is not surprising. I'll show you 2 of the most common risk factors for having resistant hypertension, I think, are obesity and older age. And certainly in the U.S., I suspect worldwide, we're getting older and heavier as a population, so we can anticipate hypertension becoming more difficult to treat. These are the risk factors, some of the risk factors. This is from a very large analysis that John Sim did. He's at Kaiser Permanente in Southern California. I think this analysis included over 60,000 patients in their treatment program that having resistant hypertension based, again, purely on the definition. And you can see, and it's been shown now in multiple cohorts in the U.S., 2 of the most common risk factors are CKD and being African American. You can see diabetes and obesity, also very strong risk factors for having resistant hypertension. And again, I mentioned obesity and older age, I think maybe 2 of the most common. So in a way, in my mind, 2 of the most important in terms of the overall prevalence and in incidence. But we all recognize a very important distinction simply between uncontrolled hypertension versus resistant hypertension. Most uncontrolled hypertension is not resistant hypertension. And that distinction, we all are we're making that distinction in the literature. I think 4 of the most common, so the distinction is apparent resistant hypertension that is seemingly resistant based on a number of medications, but obviously there are multiple causes of pseudo-resistance, so not true resistant hypertension. I think the 4 most common causes would simply be poor blood pressure technique. Most of the mistakes in taking blood pressure, I think, relate in a falsely high blood pressure level. And then a lot of studies showing that poor adherence is maybe the most common. Perhaps as many as 50% of patients are undertaking or not taking their medications seemingly at all. The white coat effect may include about 30% of patients, and under treatment is clinical inertia is very common as well as more and more medications are added to the prescription. Just a way to summarize, potentially summarize, again, there's been multiple studies that have looked at these different factors individually in terms of adherence, in terms of white coat. I like this study, not because it was necessarily the most rigorous scientifically, but it was one of the few that actually looked at the different causes in the same cohort. This was a study that David Hyman did in Houston. They'd actually done a study looking at trying to relate medication adherence to blood pressure control in a primary care setting. So they had enrolled a very large cohort, and the medicines were prescribed by the primary care physicians, but they were dispensed in these electronic pill bottles, so they could monitor adherence in terms of when they were opening the bottles and taking their medication. They also did ambulatory blood pressure monitoring on these patients. So at least in this cohort, they were able to look at both non-adherence and white coat. And so in this study, of about 140 patients with resistant hypertension, 30% based on their criteria were non-adherent, either undertaking their medicines or not taking it at all. And about 20% had a pronounced white coat effect. So combined, about 50% of patients, based on these 2 criteria at least, had pseudo-resistant hypertension. They did go on to say it was very discouraging, if you will, looking at the prescribed medications in this cohort. None of the patients were receiving chlorthalidone or spironolactone, which I think, in my mind at least, should be one of the mainstays of treating resistant hypertension. Only 40% of patients were even receiving the maximum ACE inhibitor or ARB, which is very discouraging in that it's pretty easy these days, I think, to get to the maximum dose of the ACE inhibitor and ARB. And only 15% of patients were receiving the maximum dose of the calcium channel blocker. So again, it really just highlights the degree of pseudo-resistance, I think, in this group of patients. I can go back. The one of these categories, though, it's interesting. The one that had, at least that we were not aware of, had not been quantified was this poor blood pressure technique. I think we all, the studies, the reviews, all mentioned it as a cause, but I wasn't aware that it had ever been quantified. So we tried to do that. in this little study that we presented just recently at ASH, what we did is went back in our clinic, and in our clinic, patients are screened sort of checked in to clinic, I think in a normal process by the clinical staff up front. Their blood pressures are taken, their medications are reviewed. And then they take what we're calling a triage blood pressure, so the normal routine clinical blood pressure, and they have an automated device they use. Watching them do it, I think there's only one size cuff they use in everybody. The patients are not often, unfortunately, per routine, they're sort of sat down right in the middle of the sort of intake area with all this other activity going on around them. They're being asked questions, in front of other people walking by. So it's not the ideal, but I bet it's not unusual. And then they're taken from there into our examination rooms, and at that point, we take over, and we hopefully do a good job of taking their blood pressure. We have them sit quietly for 3 to 5 minutes. We have them sit in a chair with their feet, supported, their back supported. And then we use the BP True device, so that Canadian device. It takes 6 blood pressures serially, automatically, and it averages the last 5. We put this device on and actually leave the room, so there's no clinical staff in the room as the blood pressure is being taken. So taking that as sort of expert blood pressure level, we were interested in how do they compare, and you can see here, this is again just from that abstract, you can see that the triage blood pressure in the same patients, probably taken about 10 minutes apart, you can see there's about 150 versus 135, so about a 15 millimeter difference in mean blood pressure, higher during the intake process. And when looking at it, we calculated that about 20% of the patients referred to us with uncontrolled resistant hypertension were actually, in our clinic, were being falsely diagnosed with uncontrolled resistant hypertension simply based on that triage blood pressure versus based on our blood pressure level. So again, we need to do this prospectively, but I think I do think it emphasizes again how patients can be misdiagnosed, at least in terms of if the blood pressure is not measured well. We, again, have been very interested in trying to identify mechanisms of resistant hypertension, and we've looked at the role and have become convinced that persistent fluid retention underlies a lot of the resistant hypertension. This is a study we did looking at using BNP and ANP as an index of intravascular volume, which in our clinic actually corresponds fairly well with intracardiac volumes by MRI, and it goes down in relation to changes in these intracardiac volumes. So we do think it's a fairly good index of intravascular volume. And you can see that in patients with resistant hypertension, we found that the ANP and BNP levels were both significantly higher than our control patients being largely either normotensive or controlled on a single medication. It's not surprising that the yellow and the green are the resistant patients, and the yellow is the patients with the high aldosterone levels versus resistant patients with normal aldosterone levels. And you can see that both have significantly higher ANP and BNP levels. And this is in spite of what you would consider normal diuretic use in these patients. At the time was largely hydrochlorothiazide, but you can see this. We think evidence of this persistent fluid retention in these patients. And so we feel like what some of the more important factors in terms of contributing to that treatment, that fluid retention, are we and others have shown that hyperaldosteronism is common in these patients. Obesity, we think, contributes importantly. These patients tend to be more salt sensitive, as is true of African Americans, which is about 50% of our clinic. CKD, no doubt, contributes to this increased fluid retention, as does high dietary salt intake. And so I mentioned one of the mainstays of treatment in our clinic is using spironolactone. We had shown in an open label evaluation that adding low-dose spironolactone in our hands, it was about 12.5 to 50 milligrams on top of an average of 4 medications, accomplished about a 25 millimeter reduction in systolic blood pressure at 6 months follow-up. There have been a number of, again, I think largely open label assessments or uncontrolled assessments showing similar benefit. There's a very important paper that Brian and Morris and Tom came out today, in fact, in Lancet, the Pathway 2 study showing, I think, no doubt, the most compelling data demonstrating the superiority of spironolactone over other classes of agents in their study. I think it was a beta blocker or an alpha antagonist, but clearly spironolactone was superior. So I think firmly establishes that spironolactone should be at least the fourth drug when added to existing regimens with patients with resistant hypertension. And I think Morris or Brian are going to present that data on Wednesday morning, so I'm looking forward to that discussion. But what's interesting in this little analysis that we did is that not surprisingly, the high aldo patients benefited with spironolactone, but it was, and we were surprised that even the patients with seemingly normal or low aldosterone levels had the same degree of benefit in our clinic. And so I've remained very intrigued by this. Why does it work so well seemingly across the board? I don't have the data because we've just recently analyzed it, but we're working on a manuscript. And we have found that one of the mediators of this response is actually sodium, dietary sodium intake. We are finding that spironolactone, that there's a benefit of spironolactone in patients on a high sodium diet independent of aldosterone levels. So the higher the sodium intake, the better the blood pressure response, again, independent of the aldosterone levels. So we feel like that spironolactone may be particularly effective natriuretic in these patients on a high salt diet, and we're hoping to, again, that manuscript is in preparation. The other thing that I feel like is very important in terms of treatment is chlorthalidone. I understand you guys don't use that so much here, but in our clinic, the combination of chlorthalidone and spironolactone is especially effective in terms of treating resistant hypertension, and that's one of the first changes we make. Most of our patients still come to us on hydrochlorothiazide, so one of the first things we do is switch them over to chlorthalidone, and then that in combination with spironolactone, we often get a very large response. So in summary, in terms of resistant hypertension, again, the prevalence is probably 15 to 20% based on medications. Obviously, a lot of that is pseudo-resistant. You can see risk factors, older age and obesity especially. And again, in terms of mechanism, we feel like as a group, resistant hypertension is largely defined by this fluid retention that has to be overcome. But in treating a lot of resistant hypertension, we recognized there was a group of patients who were different in that we could never control their blood pressure. They were failing all classes of agents, and it was a small group of patients, admittedly, but I was always struck by this group of patients. So we recently have revisited that group of patients, and just for lack of a better word, we're referring to them as having refractory hypertension. Now, I recognize historically resistant and refractory have sort of been used interchangeably. I think more so resistant hypertension. If there's a better word for the group, I'm happy to entertain it, but we've simply been referring to them as having refractory hypertension, which we're defining sort of conceptually, if you will, as failing maximum antihypertensive therapy. And that obviously is going to be somewhat arbitrary, but I'll show you what we've settled on. Our first assessment of this group of patients was a retrospective analysis of patients who have been referred to us for resistant hypertension. And we went back and looked at their blood pressure control in our clinic. And you can see that of about 380 patients referred to us for resistant hypertension, by a year's time, we were unable, and if they had adequate follow-up, which we did require three follow-up visits, that we were unable to control not control about 10% of those patients ever. So it's a small percentage of patients referred to our clinic at least, but it was not insignificant. And again, it's a very, very unique group of patients. And the other thing that was striking to us, this is some of the mean values for this retrospective analysis. So this analysis ended up including 35 patients with refractory, 140 with controlled resistant as a comparator. What was different was seemingly consistently across this group of patients was their higher resting heart rates in clinic. They seemingly always had a higher heart rate than patients with controlled resistant. And this is in spite of broader use of beta blockers, beta antagonists, which you would think would have blunted this effect. So we decided to design a prospective evaluation, trying to better characterize and test mechanisms in this group of patients. So we set up this prospective evaluation. So the first hypothesis is based on that heart rate difference. Our hypothesis was that refractory hypertension is more neurogenic in etiology. That is, is attributable more to heightened sympathetic tone as opposed to this fluid retention that we feel like broadly characterizes resistant hypertension. So we wanted to look at some indices of sympathetic activity. We couldn't, microneurography would have been the best way to do it, but we're not doing that. So we looked at 24-hour urine norepinephrine excretion, clinic and ambulatory heart rate, and heart rate variability. Then the alternative hypothesis, and really the competing hypothesis, is it's not neurogenic any more so than resistant, and it's simply maybe worse cases of fluid retention. So we wanted to again look at indices of fluid retention, so aldosterone levels, response to intensive diuretic therapy, and then we also measured thoracic fluid content by bioimpedance in this group of patients. And again, our comparator group is this patients with control, and who were referred to us also for resistant hypertension, but in whom we could eventually control their blood pressure. So this analysis over about 3-year periods originally we screened over 700 patients referred to us for resistant hypertension. You can see we made our way down. A lot of them, in fact, were controlled or weren't on a reasonable regimen. Some we suspected were not adherent. And in this prospective analysis, we ended up identifying only about 15 patients in whom we felt like, or who had what we were calling refractory hypertension, in whom we could never control their blood pressure, given adequate follow-up. So only now about 5% of patients in this clinic. And I think, a little bit slightly lower prevalence rate in our clinic. And I think that's largely just simply using now chlorthalidone and spironolactone on a much more systematic fashion, and even during the period of that retrospective analysis. So we're looking at a small number of patients. We enrolled on a 2-to-1 fashion patients who were controlled, having been referred to having resistant hypertension. So the analysis is going to include these 15 patients with refractory hypertension, and then almost 30 patients with controlled resistant hypertension. I apologize. I'm not very clever at making slides, so I'm simply taking the tables out of the manuscript. It was published last month in Hypertension. I should acknowledge the lead author in this was Tanya Dudenbostel, who's the assistant professor in our group in Birmingham. So just quickly, in terms of some of the variables, number of medications was 6 versus 4. You can see in clinic much more severe hypertension, obviously by definition. And again, we see even a larger difference in heart rate in baseline clinic value, 75 versus 63 in these refractory patients. In terms of some of the demographics, they tend to be younger, so it's not simple, or in fact they were significantly younger. So not simply older patients with systolic hypertension. They were more often female. And also more often African American. So what we see is in this group of patients, the most common subgroup, if you will, is African American women, and they are not more obese than the patients with resistant hypertension. So it's not simply because they're heavier. In terms of the risk factors, similar in terms of renal function. The only difference was these patients, even though younger, had already had more frequent hospitalizations for congestive heart failure, almost exclusively diastolic heart failure, so preserved ejection fraction. Looking at the 24-hour ambulatory results, you can see these patients had very severe hypertension even outside of clinic, almost the same as in clinic. And it's interesting, we have so far seen no white coat hypertension in these patients with refractory hypertension compared to the patients with the controlled resistant. What is also interesting is we're seeing a fairly high proportion of masked hypertension in these controlled patients. A lot of them are controlled in clinic, but their ambulatory pressures remain high. So we're evaluating that in more detail. The other thing I want to emphasize is you can see it's true both 24-hour and both daytime and nighttime. And the other thing that was let's see, significant was the heart rates also were significantly higher in these patients during on ambulatory monitoring. So we confirmed what was observed in clinic on the ambulatory heart rate. And then lastly, metanephrines, 24-hour norepinephrines were significantly higher in these patients. In terms of the volume status, BNP levels were in fact tended to be lower. Aldosterone levels were not different. PRA levels tended to be higher. And you can see 24-hour urine and aldosterone levels are not different. So we don't see evidence of this fluid retention in these patients. And also, they don't respond as well to diuretic therapy. You can see in these refractory patients, the controlled patients, again, about 25 millimeter reduction in systolic blood pressure with spironolactone, about half that with refractory patients. And this is typically at a higher dose. So they're resistant to this intensive diuretic therapy. So in conclusion, we've discussed, what is this a true distinction? I mean, we admit it could simply be artifact at this point. So if it is, why might it be, not a true distinction yet? It could, obviously, the biggest question is, are these patients simply, we know they clearly have severe hypertension, but are they just broadly non-adherent? Are they not taking any of their medication? So we have stored urine, banked urine on these patients, and we will be doing the metabolic analysis, the metabolite analysis to identify whether they've been taking their medicines or not. That's obviously a leading consideration. Perhaps they're over-diuresed, and that's contributing sympathetic tone in some fashion. I don't think so, because even before we intensified their diuretic therapy, their heart rates were higher, BNP levels were not higher. Could vasodilator use be contributing to their higher sympathetic tone or underlying congestive heart failure? And perhaps we're even perhaps the patients with controlled resistance are in fact the ones taking their beta blockers, and that's why we see the difference in heart rate. I don't know that would explain the difference in norepinephrine levels, but it's a possibility. So if it is a true distinction, there is a higher neurogenic tone in these patients. What might be the causes of that? So we're looking at possibilities including sleep apnea, genetics. We're storing DNA in these patients. I don't think it's going to be genetics. These patients are exceptional even within their own families as far as we can tell. And then one thing we're also looking at is stress, anxiety, perhaps coping mechanisms in terms of contributing to this heightened neurogenic tone. So I'll actually, to try to stay on time, I'll stop there. This is my summary slide. I'll leave that for you guys to review. But again, thank you so much for the invitation to be here.
David, thank you very much for that. Do we have any questions for David from the floor? Adrian, I think you've got a question.
Yeah, David, thank you very much. I mean, one of the big themes at the ESC this year was about adherence, compliance, concordance, and so on. And witnessed tablet taking, which is something that we do in our own clinic in Glasgow. And is this something that you've taken on or adopted in Alabama?
We've certainly not been doing that. We haven't done it yet. I will say, though, we have just recently submitted a protocol to the IRB, which we will do exactly that. We're going to bring them in and feed them in clinic and look at that prospectively.
Because when we do it, the nurses stand by to catch the patients as they collapse when they give them their 7 antihypertensives.
That was my question: is how long do you watch them in clinic?
They have to bring their own medications with them, unfasted, give them their tablets, and then monitor them for about 4 hours afterwards. If they collapse, they usually collapse within the first hour or two.
Okay, well that's very reassuring.
Some quick questions from the floor, if we can. Franco Capuccio.
David, just following on, we now more recently have adopted the measurement of urinary metabolites and seems to reveal quite interesting proportion of patients not adherents. One thing has come out quite clearly, which I haven't seen amongst your potential causes for non-adherence, and is becoming more common, is problem of gastrointestinal absorption. In other words, malabsorption of drugs due to a variety of reasons. You mentioned obesity, so obviously bariatric surgery is one reason, colectomies, IBS. Do you have any experience in this regard to isolate those that are really truly non-absorbing, and what would be a solution for them?
All right. Now, I have to admit that we don't have that. I don't have that personal experience so much. I think no doubt it's likely true. Unfortunately, Alabama has the highest obesity rate in the United States, or I should say second highest, second only to Mississippi. And so we have a very busy bariatric surgery service. And so we do see a lot of patients before and after that surgery. So a lot of those patients do remain very resistant to treatment, so perhaps that's contributing. But we haven't looked at that formally at this point in terms of the possibility of malabsorption.
So 2 quick questions, Mel Lobo and then Una, and then we'll have to stop.
2 very short questions. One, do you ever consider medicines intolerance as an important cause of failed adherence? And secondly, your pulse pressures in your refractory hypertensives are much bigger, and I haven't heard you talking about arterial stiffness as a potential underlying cause.
We did measure pulse wave velocity in this cohort, and they do have a higher arterial stiffness based on that, even though they're younger. And then in terms of intolerance, yeah, certainly that's very common. They certainly all have experience with that. I wouldn't consider that. I'd say that's certainly a cause of uncontrolled hypertension, but if they're not taking it for whatever reason, and I really wouldn't consider that resistant. So it's certainly difficult to treat, but not necessarily resistant hypertension. But that's just sort of arbitrary.
The last question, Una Martin.
I wanted to ask you about your approach in your resistant group to diuresis and kidney function, because it seems to me a lot of the time when we go aggressively after diuresis with indapamide, in our case and spironolactone, we kind of get scared because the kidney function goes off a bit. And do you think we do our patients a disservice rather than gritting our teeth and carrying on and letting the kidney function settle, whether we're too neurotic about fairly minor changes and that we're actually preventing ourselves getting them under control?
I think we probably are. Talking to our nephrologists, they're not bothered by small increases in creatinine. In fact, they take that sometimes as an indication, a good indication in terms of reducing the intraglomerular pressure in those patients. And so I think you're probably right. If we were a little more courageous about accepting those changes, we might do a better job of overcoming that persistent fluid retention.
David, many thanks for coming all the way from Alabama to share your experience. We really appreciate it.